Introducing young dynamic lady of passion and perseverance, Dr. Vrushali Ponde from Mumbai. With a special talent and skills and passion for excellence, she has edged a dominant position of Managing Trustee and Founder Secretary of AORA, that is Academy of Regional Anesthesia in India, for herself. She is Director of Children's Anesthesia Services, Mumbai. She is ex-co-member and ex-secretary of Asian Society of Pediatrics Anesthesiologists. She has 2 editions on Illustrated Manual US GRA Anesthesia in Adults and Children. She is program leader and academic head of WFSA Children Anesthesia Services, Pediatric Regional Anesthesia Fellowship, Mumbai. She has 35 international and national publications in her name. Runs a bi-monthly simulation-based ultrasound-guided regional anesthesia skill course. To add to all this academic activities, she is a wonderful sitar player and performs regularly as a student of Halim. Her lecture for today is about perioperative pain management in pediatrics.
Such a benevolent introduction, and thank you so much. The best part is that she started with a young lady, so which makes me the happiest today morning.
Inspiration for all of us, madam, indeed.
Well, on a serious note, I am extremely thankful. So I know we are running with time, but I can see Golabs are absolutely comfortable, and so we all speakers are taking our liberties to chat with you all very liberally. This is not a very common occasion. That otherwise generally the sword of time is always hanging on us, but everybody seems to be quite chilled, so it's such a welcoming scene. Well, coming to perioperative pain management in pediatric patients. So this is what we are going to discuss. So Ankit has come, he's induced the child. Dilip has come, he's inserted a supraglottic airway. So now we are about to start the surgery, but before that we have to think of intraoperative and postoperative pain management. So my friends have laid the entire background for me. So either I put the LMA, I don't, either I put the tube, I don't, either I midazolam or I use SIBO or I use halocaine or I do nothing, I do an IV induction. One thing remains constant in pediatric anesthesia is pediatric regional anesthesia remains intertwined with pediatric anesthesia unless and until there is a good contraindication to do so. So this is what is actually the basis, because friends, it's 80,000. 80,000 is the number of hours a routine anesthesiologist is going to give anesthesia. If we need to be of value, we will earn, and we will probably earn some reputation as well, but if we need to be of real value, along with the safety, if there is anything we should be taking care of, is perioperative pain. Because that's one thing, if anybody tomorrow wants to go for an operation, other than life and death, if there is something for which you get worried for, is pain. So what you need to do is you need to be very vociferous about this particular aspect, and by very simple things you will be able to achieve the goal of at least reasonably well pain control. So now let's get on with our job. Secondly, life has become extremely fast-tracked today. In the sense, more and more surgeries are getting converted into daycare surgeries. So, you know, some 15 years back, surgeries which we thought that the child was going to remain for 2 days with us now goes home the same evening. Say for example, neonatal bilateral hernia, very typical example. By evening they go home, they're in the cradle at night, their own cradle at night. So this is how things have evolved. And they're usually on Saturdays, so that parents have a holiday on Sunday, so they also do not have to kind of take a special leave. I'm talking about the father because neonatal mother most probably is at home. So now let's get going now of this aspect as well. So there are fast track surgeries and there are major surgeries, and I think when it comes to pain management, the principles must remain the same, whether it's a minor surgery or a major surgery, whether it's a neonatal surgery or it's an adolescent surgery, whether it's an in-house surgery or it is a daycare surgery. The principles remain the same. The way we are going to manage these principles will differ as the surgeries differ. So there are certain things that we are going to look into first before going into it. Clear myths about pain perception in small children. Luckily, we have overpassed this now. Understand consequences of acute uninhibited pain. How do we assess pain? Because unless we do not assess it, we will not be able to treat it. Seek the best options to manage perioperative pain. That's the chunk that is going to be spoken to you all about. Pharmacological management, yes, of course, sometimes we need to fall on this as well. Regional anesthesia techniques, I call it the Mercedes of pain management. Complications and predicaments for that. The regional anesthesia technique is what I meant here. We are going to look into that. Parental involvement, they have a huge role. Let's see how we use them. Well, myths versus facts, it used to be frightening a while ago, not a while ago, decades ago perhaps, that the smaller children do not feel much of pain. Gone are those days. It was frightening to think like that. Today it's proved that the youngest of the neonate will have the lowest of the threshold for pain. So please remember this statement. Hence, when you do a neonate, at least try and insert a paracetamol suppository. Secondly, as they grow up, they are going to forget the experience of pain. They will probably not remember how painful the perioperative period was, say of a 2-year-old child. Yes, the child will not remember, but memory is not the only scaffolding on which pain hangs. Pain can change, acute uninhibited pain can change certain things in the nervous system to an extent that it becomes more prone for chronic pain. We call it plasticity. So it kind of pushes it towards that side. So it's our job now to take care of acute uninhibited pain. Well, having said so much, take a note of this question and also see who's asking this question. Nursing Journal is asking this question. In spite of having good analgesics, why is suboptimal pain management still going on in the surgical wards? This was asked in 2004. 2012 is giving us a good news. All the good pain control was commonly achieved after surgery. Improvements may be possible by increasing the use of multimodal analgesia, providing standardized written discharge instructions, and using surgery-specific pediatric analgesia guidelines. So now let's see how have we gone here. Well, procedures commonly performed are these, and which are on the daycare basis, except perhaps hypospadia is repaired here. Most of them may go home on the very same day. Coming to surgical criteria, there are major pain surgeries, there are moderate pain surgeries, there are minor pain surgeries. They have nothing got to do actually with the duration. A typical example is a hernia surgery. A bilateral hernia surgery may be less painful than a circumcision surgery, although a bilateral hernia surgery may appear longer than a circumcision surgery. So we need to be a little more bit careful while we give the analgesic dosages regime and we pick up the regional block for these kids. So now now that I have given you an example where it fits well, the journey of pain management starts right from here. Everybody here is going to agree with me. A child who sleeps while crying, wakes up while crying, a crying child in the postoperative period will always be mistaken for many other things, and pain may be one of it, especially if the child has not yet spoken. I mean, if the child cannot speak, he will not be able to say what's wrong. They'll be agitated. So I think one of the best strategies of handling pain is handle the children in the pre-operative period well, see to it that they're well pre-medicated. The excuse given these days, or perennial excuses, we do not have enough time to pre-medicate. I beg to differ from this particular point because we are a private practicing group. If you have an IV line already, it doesn't take much time to give midazolam, a wee bit of ketamine, glycopyrrolate in the mother's lap. The child sleeps, pick up the child and get the child inside. If you have just come from one nursing home and now you're going towards another, make a call, get the child down, get the midazolam ready. Before you change, give the midazolam to the child, while talking to the mother, change, go and put up your trolley. This is going to give you a good 15 minutes. We can even hike up the dose of midazolam to 0.75 milligram per kilogram, and that gives you a good amount of action. He may not really be very drowsy, but good enough at least that you have not performed a gorilla induction. Okay, so we start with a very, very smooth induction and of course prior pre-medication. And pre-medication, remember, gives you one chance to pick up that particular sensitive, fearful child, a child who cannot make an eye contact with you, a child who kind of shrinks beneath the mother. These are the kids who are not even going to open up much to you anyways, no matter how much time you spend. So you do need a lot of pharmacological assistance to keep them completely comfortable with you. Pre-medication we have spoken of. Now let's come to pain relief for surgeries. Each surgery will be different. Please don't go by your own opinions. I might feel that this surgery may not may not cause much of pain. The surgeons are going to have their own opinions. We are not going to fall on opinions. We are going to be objective, and we are going to take care of pain by assessing it. So there are various scores. The easiest one is for those who can speak. It is very easy simply to ask the child. Don't even go for scoring. You just have to ask whether it hurts or it doesn't hurt. A child who can talk will definitely say you don't need a score. If you want a score, that score is more helpful for children who cannot talk and vocalize their pain. So that is the time. Fall on very, very again simple things such as, is he crying more than usual? Is he playing less more than usual? Or is he holding the sore part? There are very, very simple criteria. The was or the ouches or the chips or the cheops, they all are there, but you can fall back on something very simple in your day-to-day practice. Give a mother her own pain score in her own language, she will understand it better. Parents are the best people to give you the pain scores of children more than the sisters, sometimes I feel. Because sisters will be nagged when children are really, really cranky. Till then the sisters may not come into role. So pain relief modalities, we have a rule of 3 here. First is pharmacology, regional techniques, and multimodality, that is taking the best of both. So let's come to pharmacologic aspects of it. It has to be a dosed appropriate analgesic. That's where we falter, I think, because we write analgesics, but it may not be milligram per kilogram basis with exactitude. So that's what we need to be doing. And then we need to think whether we need to be SOS or we need to be round the clock. A simple gesture such as looking up at your surgeon's prescription for pain will go a long way. They somehow have a habit of writing it SOS because the whole world is paranoid of disadvantages of pain relieving drugs rather than the advantages of it. Alright, so see to it that the analgesics are given round the clock, and whether it's a syrup or a tablet or a rectal route is absolutely up to the child's age and preference. Can I have the sound for this? Because I insist, because I cannot emulate the sound no matter how well I try. I will go back because I don't want you to miss a single word of what's happening here. No, it's not coming out of the... Pen. I heard something. Didn't I? So before checking it, I should have checked the voice as well. Okay, this is a scene from a movie called as Term of Endearment. This is a child who's gotten operated. The child is in the room, of course not too comfortable, which is reflected in the mother. So the mother comes out and she asks the the staff here, to administer the painkiller, and she insists upon the time. I'm missing the sound a lot, but this is what she's trying to say. The sister says that I am going to give it in some time. This sister tells her that, look, this is not my patient. The mother goes mad. She's shouting all over the place. I may try at your risk to shout that way, but I would refrain. So now this happens. And finally she gives up and goes and gives the pain shot. And finally she thanks everybody here. This is not what we want. We want a very clear-cut pain management done for children. So how do we want our kids? We want our kids to look like this. I know it's an ideal scenario, but something has gone extremely right here to have this scenario. So we want a child like this. I know it's something too much, but you can try. So the take-home message is reasonably round-the-clock administration of suggested drug regime. It can be, I have said it right, suggested because it can be a renal disease case, it can be a liver disease case, or it can be an ASA1 child. So things are going to be different, and all of them deserve pain relief. Child preference